This is a Defocus Media production.
Defocus Media, Optometry's #1 podcast, welcomes you to Eye Care Shenanigans, where Doctors Jeff Fardink and Daryl Glover discuss the latest in eye care trends, news, research, and more. Hello there, everybody. Welcome to this month's edition of Eye Care Shenanigans. Dr. Glover and I, Jeff Fardink, we got some great articles ready for you. Dr. Glover, how are you doing this week?
Hey, man, I'm doing fantastic. It's been a hell of a week. You know, whenever you have these short weeks, they end up turning into long weeks, right?
Absolutely.
It's like you got to catch up, right? I mean, Monday we were off for the holiday, and now I feel like I'm scrambling. It's been nonstop personally and also professionally as well, my friend. How about yourself?
I couldn't stick the words out of my mouth. My little man just started kindergarten. It's his first week in school, and that's been crazy, but it's been awesome. He's having a great time. I'm loving seeing him, watching him go.
Hey, man, you got to cherish every moment with these young ones because It just goes by like that. You know, I remember when my son was just born, right? And now he's 6 years old. He's in first grade. He's reading books. You know, he can understand, math. I mean, we can't just spell out things anymore because he's sitting there doing it in his head. And my wife and I are like, oh my goodness, we opened up a world of trouble. It's a good thing. We want him to be able to read, but
right.
He can't be slick anymore, right? So just a word of advice. Be careful with what you say now moving forward.
Absolutely. Yeah, we got to be careful. Sometimes my wife and I will spell things to each other, trying to hide it from him. And it's not working anymore.
Yeah, definitely don't do ICECREAM because they know what ice cream is and how to spell it. That's one of their favorites, at least in my household, I should say.
Yeah, ice cream and he'll scream, and that's how it
I love it, man. I love it. Well, man, hey, I'm super excited because we get to partner up. You know, every month we do this segment, Eye Care Shenanigans, where we bring the latest and greatest and the hottest topics and trends in eye care. And I know you always bring it in a very digestible manner where folks can take this information and implement it into their practice. And today I want to go ahead and get started, man, and kick it off. You know, our first topic is antiseptics versus antibiotics. Let's talk about it, my friend.
Yeah, I've got some interesting ones here. These articles, I hope I don't sound like a fool bringing these up because these are most of these articles here I picked because I was reading them and they tended to have something about treatment that I wasn't aware was even really a thing. So that's why I brought these up, helping me educate some of my colleagues out there. So a retrospective study done with corneal foreign bodies, mostly rust rings, removed either with needle or Elger brush, just checking to see, antibiotic eye drops or antiseptic eye drops, what is going to give better outcomes, if any. Quick review of the difference. The goal, of course, here is to prevent infection. Antiseptics will treat the surface and keep it clean, disinfect the area, preventing infection and the spread of bacteria. Antibiotics are more for, of course, treating infection that's already there and also, hopefully preventing infection that comes on. But with antibiotic resistance growing, it's important to try to use antiseptics more when that's appropriate because we're not going to have the issue of antibiotic resistance. And also antibiotics can sometimes have more side effects, whereas antiseptics typically don't tend to have that. So in the study, tobramycin or picloxidine was given to patients after corneal foreign body removal. They were on the drops for 4 times a day for 7 days, followed up 1 week and 1 month. And they checked to see how frequent was infectious keratitis in these patients and checked on the outcomes. And about 5% of patients, even with the treatment, developed infectious keratitis about equally if they were on tobramycin or taking the picloxidine eye drops over the course of the 1 week period. And that was the thing that was new to me, is I wasn't aware that you could even give patients antiseptic eye drops to use on their own. I'm not sure this was prescribed or given to the patients by the doctors, but it's a thing that you can do. Apparently, it was news to me.
Yeah. And, this is great information here, right? Because we know that our patients don't always come to us first, but they should when it's anything eye related. But a lot of times they may go to their PCP or ER or urgent care, right? And they may actually use this opposite treatment that we normally do, right? So it's good to be well versed in it before we just start talking crazy about the doctor that they call, right? So it's good to be educated about these different methods of treatment. The thing that got me, man, that I thought was hilarious was that they did the sample was based off of men.
Yeah, right.
I guess they're the only boneheads that actually get corneal foreign bodies, right?
Yeah, right. Well, I removed a big rust ring from a lady recently. she was holding something up for a man who was drilling, but hey, she still had the rust ring.
You know, my daughter always makes me nervous because she has now become infatuated with my eyes and my glasses. And whenever I don't have my glasses on, she's still always trying to put her finger in my eyes. Right.
Absolutely.
So I don't know if she knows that her daddy's an optometrist or what, but I get nervous about corneal abrasions, foreign bodies, because I'm afraid she may try to stick something in my eye. So, you know, all my parents out there, beware. Kids like to use their fingers and go towards your eyes. All right.
Those infant fingernails too, man, they are sharp. I get lots of corneal abrasions from unsuspecting new mothers coming in with their little babies getting too close.
Absolutely, absolutely, man. Something that I love when I get these abrasions is definitely amniotic membranes, man. I've been using those quite a bit. We've had the opportunity to leverage those at my practice, and we started really leveraging them maybe 2-3 months ago. And when I tell you, man, those patients come back 2-3 days later, their corneas look incredible.
Wow.
No scarring, they feel significantly better, just truly a game changer, and great for reimbursement as well.
Yeah, I need to start doing those more. I haven't really used those very much.
Yeah, step your game up, my friend.
That's right. And so some more takeaways from the study here. Really, there was not much difference at all in outcomes if the patients were given the antiseptic or the antibiotic eye drops. Infectious keratitis, about the same rates, about the same number of patients had to go on steroids to prevent issues in the future. So about equally effective.
Awesome. Awesome. Well, let's take it to the next hot topic, my friend. Pain and depression. What is that all about?
That's right. Well, so we might have touched on this once before, but it's just an interesting topic to me. So I do a lot of specialty contact lenses, and I love to fit scleral lenses on patients who've got, painful corneal problems, dry eye, things like that. I remember the first time I had a patient come in, she looked fine. First time I had a patient come in and have this issue I'm about to describe. So she was recommended to try sclerals. That's why she was referred to me. She's had a long history of corneal pain, had trouble with soft contact lenses. The first red flag, of course, was that giving her the anti-aesthetic eye drop didn't really seem to help very much. And then the second red flag was you put the scleral lens on, and man, she was not having it. She felt almost worse with that scleral lens on, which was just shocking to me the first time this happened. Yeah. And this was, of course, of this neuropathic corneal pain, where there aren't really any corneal signs that are obvious there as a provider to look at, but the patient's in a lot of pain. And it turns out, perhaps not surprisingly, that there's a big correlation here between pain intensity and mental health and poor quality of life. So typically, there's more going on with these patients. Their pain's a real thing, of course, but there's more going on that's not really on the surface of the eye.
I love that you touched on that, man. And mental health is a big deal, right?
Absolutely.
And we got to keep in mind that when patients come into our practice, yes, they're coming to us as eye care experts, but they're also coming to us as psychologists, psychiatrists, a friend, a loved one, because we get to spend more time with these patients than other doctors do. So they really sometimes can just unload on you at one time. I've had patients come in and we've sat down and we've cried together. I've had patients come in and we've prayed together. I've had patients come in that just wanted to talk more about travel, food, whatever it may be. But, you just always want to be prepared for those patients that come into your practice and make sure you have those real conversations with them, but just be there for them more than anything.
Yeah. I couldn't agree more. Of course, my most common referral source I refer out to, of course, is ophthalmology. Second most common is back to primary care for systemic issues. But a close third there, I'd say, is mental health. I refer a lot of my patients to mental health providers, and don't be afraid to do that. It can be a great resource that other providers might not be recommending to the patients that really need it. So.
I agree, man. And just the medications in general and what they can do to the eyes. I mean, we got to be educated, abreast of the latest and greatest news. And that's what we bring you here, baby, on Eye Care Shenanigans.
That's right.
We bring the latest, greatest topics out there. Now, the next topic. I know this is your thing, so I'm going to let you take the shine on this one, but we're going to bring it home, baby. Here we go.
Where we bring you the latest action in the science of refraction. That's right. Welcome to Back to the Pre-Optometry, everybody. So I love to always have a topic where we talk about maximizing our patient's vision, refraction, things like that. And so this month, I wanted to bring up actually a case study that I had a patient of mine. This is a patient I've been following for a while. She's a high school age girl. She's basically an emmetrope. Her refraction's like +1/4, -50, not much going on there.
Okay.
She's had some binocular vision issues. I worked with her with prism spectacles before and had some success in vision therapy stuff. But she's now she's starting to drive, and she's had a tough time with kind of glare and halos at nighttime, and really wanted to try contact lenses. And this patient's basically an emmetrope. What are we going to do? So if you have a patient like this, you can, of course, go to rigid contact lenses. Rigid lenses have excellent optics that might provide the edge, but that's a tough sell, I think, to go with a patient who's got basically no visual needs into a
Right.
rigid contact lens. So yeah, I've done things like that before, but that was not my first choice here. What I ended up trying with her is the Bausch & Lomb Ultra contact lenses, -1/4 in both eyes. Before I did this, I talked to her and her mom and said, listen, you don't really need this for the refractive correction. I don't know if you're going to see much better here, but these lenses have some excellent aspheric optics. I've had patients tell me that they feel like they can drive better at nighttime with these lenses than any other correction they've worn before. So,
Wow.
let's try it. We put those on there for her, and man, it made a huge difference to her. She could really notice a big difference in her vision. She had a confident 20/20 in both eyes after that, where previously it was kind of like a 20/20 minus, really without correction. So, even be willing to try things like this. I don't promise the world, but I was very surprised at how well it works, and happy the patient was happy with it.
Yeah, I mean, for me, it's all about the out of the box thinking, right? Patients
Yeah.
are coming to you with a problem. It's up to you to find a solution. Funny story, man. I had a patient. Actually, it was one of my sister's friends. We were having a conversation at a cookout this past holiday, and she was telling me that she went to an eye doctor, and she has a history of having LASIK, and she was having some difficulties with driving at night. And the doctor was essentially saying, hey, your vision is great. And it's because the way that her refractive surgery was cooked out or made was to be more of a monovision style, right?
Mhm.
But the doctor didn't listen to the patient. She was having problems with driving at night. And we know if you have
Right.
that monovision setup, what are you going to have problems with? Depth perception, right?
Yeah.
So she needed that extra layer of a pair of glasses to fully correct for distance with a good anti-reflective coating like a Cazal Rock or something like that to really make a difference with her driving at night. Sometimes you just got to sit down, listen, not run your mouth. I know that when we walk in that exam lane, we already know the answer more than likely before we even see the patient, right? But sometimes you got to just sit back and let that patient talk and listen to them to find the best solution. And this is a clear case that you presented. When you listen to your patients and think outside of the box, you can really elevate that patient's life. But most importantly, you got a patient for life.
Yeah, I couldn't agree more. You got to be willing to try things. And what you brought up is great. I love multifocal contact lenses, but I've got a lot of patients that are happy in monovision contacts. And, not a bunch, but I prescribed a handful of those patients some glasses to wear on top of their monovision contacts for when they want to just have the best night driving vision. So, I've done things like that too. I prescribe monovision glasses to those patients sometimes before too. Think outside the box. You can meet patients' needs sometimes doing things like that.
I love it, my friend. I love it, my friend. Now, this next one, when you sent me and I looked at this photo, man, I almost fell out my chair. I couldn't believe
Right.
what I was seeing, right? This next one up is raccoon sign. This is a game changer here. Take a look at
Right.
this photo. For those that may not
Yeah.
be watching this on YouTube and listening to audio, I strongly urge you to go to Defocus Media on YouTube and subscribe to begin with. But check out this photo because this will blow your mind. Dr. Fardick, man, you got to share with me on this one, my friend.
You got it. So the photo we're looking of is of NASCAR driver Ryan Preece. He was in a really nasty car accident last week while driving. I encourage you to check out the video on that, man. The car, it flipped probably 12, 13 times quickly. And man, I'm surprised this guy's alive, let alone a week later, he's cleared to race again. He's didn't have any significant injuries from this, which goes to talk about the incredible engineering involved in those cars. But man, he thankfully is okay. But you look at him, and he looks a little banged up here. He's got black eyes. Both of his eyes are black, and he's got big subconjunctival hemorrhages in both eyes. Both eyes are blood red. And this is a classic case of raccoon sign or panda eyes or raccoon eyes. So, sometimes you'll have patients come in like this. And what you want to be aware of course, when you see this is that apparently this wasn't the case here, thankfully, but this is generally an indicator of a basilar skull injury where there's a damage to the base of the skull that causes blood to come forward and pool like this. And that requires an emergent referral. So just something to be aware of. Sometimes you'll have patients with just the big double subconjunctival hemorrhages. They've been vomiting or coughing a lot, and that's not concerning. But if you have a patient come in with this and they have a traumatic etiology, I'd refer right to the ER every time.
Yeah, I mean the main thing, my top concern is there some type of vascular related condition that's taking place, right? And I know the article that you shared, they were concerned about quite a few things, from giant cell issues to venous sinus thrombosis. I mean, the list goes on and on. But to your point, this is, you need to refer them directly to the ER as soon as they walk into your chair, right?
Absolutely.
Very
Yeah,
scary
common.
stuff here.
Some other things that might happen if they have the basilar skull problems. Sometimes they'll have clear fluid coming out of their nose, cerebral spinal fluid. So that's one thing to ask them potentially. Oftentimes they'll have cranial nerve involvement, cranial nerves 1, 2, 3, 4, and 6. That's a lot of the ones involved in vision and eye movement there. So
I wonder
again,
if that fluid has a scent to it or a smell to it. I mean, I've never smelled it, of course, but
the same
I'm just
here,
curious,
thankfully. The biggest thing with CSF leaks, I was an EMT for a while too, and you'd look for that with coming out of the ear sometimes.
What have you not done, my friend? Like seriously, what have you not done?
Seduced a lot of women, I guess. I don't know. Ladies. I'm happily married man. I'm done with that. But there's plenty of things I haven't done. But yeah, the biggest thing about CSF is that it's a clear liquid that comes out, and that's unlike anything that people are familiar with, blood or mucus. It's just a clear fluid. So that's the main giveaway.
Gotcha. Well, fantastic case, man. I really appreciate you bringing that one
back to the Phoropter, where we bring you the latest action in the science of refraction. I'll hear that again. I'll listen to my.
I was going to say I love hearing that all the time, so I just had to play it twice.
Why not? Yeah, I had a patient show me this guy's photo. That's why I brought it up. So it was an interesting day.
Awesome, man. Well, the next article up or next topic is not just ROP. Let's take that from the top, my friend.
ROP, you know me. So this article is very interesting to me.
Oh.
That's right. So talking about adverse visual outcomes in children born prematurely. Of course, retinopathy of prematurity is a big one. Of course, those patients are going to have adverse visual outcomes. But this article was a retrospective that delved more into patients that were premature but didn't have ROP. Did these patients still have adverse visual outcomes? And overwhelmingly, the answer is yes.
Yeah.
Most premature children, when they grow to a school age or adult age, are going to have adverse visual outcomes. Going to have lower visual acuity, both near and far, lower contrast sensitivity. And the really interesting thing here is that there's actually morphological differences in the way the retina is shaped. There's extreme prematurity without impact of ROP is associated with increased ganglion cell layer thickness, interplexiform layer, outer nuclear layer, and retinal thickness at the foveal center, as well as reduced foveal depth compared to full-term controls at 6.5. I remember hearing some of those words in optometry school. Now, those are some of the layers there, the retina, of course. So the actual shape and layout of the retina is different in the macula and the fovea in these kids. But the really interesting thing about this article is that the author really went out of his way to argue the case that it is not necessarily the prematurity that is causing these problems, but rather the insults that led to the premature birth or maybe complications after the infant was born and some of the things that happened, some of these insults that happened when the premature child was developing after the birth. So he went out of his way to say that, let's not rule it out and say that preterm birth is going to cause these problems. Let's investigate ways to prevent this from happening in children who are born prematurely, try to fix some of these insults that occur after the premature birth. So that was a really interesting takeaway there, was the optimistic news that hopefully we can prevent this and try to find different ways to treat these premature babies that are born and prevent these outcomes.
Absolutely. The thing that gets me is this really started to get me to think, right? My neurons started firing off. How many of us as optometrists ask all our pediatric patients or parents, were they born premature? Right? Or do we just wait for that whenever they walk into the office and we look at fundus photos or take a peek at the back of the eyes and we see the vessels or nerve look a certain way? Like, what kind of conversation are we having with every patient that truly walks through the door? Is this a question that we should ask all pediatric patients, or is this a question we should ask all patients now that we know that we have this data and this research here as well from this article that you shared? I mean, what are you going to do moving forward after hearing this? How are you going to implement this in your practice?
Yeah, when I've got the 6 or 7 year old kid that's coming in and I'm not getting them to refract as well as I want them to, I'm not getting the vision that I want, I'm definitely going to start asking it. I don't know if I'll ask every patient, but it's something to keep in the back of your mind when you've got that young kid or even an adult who is just not refracting, not getting the vision that you want. Something to ask, were you born premature? Was there a premature birth here? Because that could explain part of it.
Yeah, I love it, man. Always dropping gems. I appreciate it, my friend. All right, my man. Next one up: surgery versus Botox. What is this all about, my man?
So this was very interesting to me. So this is talking about the treatment of esotropia, acute acquired concomitant esotropia. Let's break that down. I'll pretend like I know what that was when I read that. Just there's so many flavors of these binocular vision issues.
Hey,
out
man,
there.
all these words scare me, to be honest with you. When you start talking this language, I'm just trying to run the other way. You dig?
No, I know, right? Yeah, eyes across. That's the main takeaway here. So, an acute acquired concomitant esotropia. Concomitant meaning that in all positions of gaze, the esotropia is constant, and acute acquired meaning that it comes on usually either around school age or sometimes in adulthood, and there's not an obvious cause for it. There's no ischemic insult that happened in these patients. There's not a systemic related problem that caused it. It just kind of comes out of nowhere with no obvious reason.
Yeah.
And what do you do to treat this? And there's no refractive error here. There's no hypertropia, accommodative problems. There's none of that stuff in acute acquired concomitant esotropia. And this study researched the effectiveness of muscle resection surgery, strabismus surgery, compared to Botox injection in the muscle. And what I thought was interesting was I wasn't even aware that you could even use Botox to treat eye misalignments. I was not aware of that. And I was, yeah, well, good. I'm glad it wasn't just me.
Yeah.
And I was like, well, wouldn't that just be temporary? Wouldn't that the effects just last however long the Botox lasts? And interestingly, the answer is no. So apparently what happens here is the Botox, it'll induce paralysis for 5 to 8 weeks in the muscle. And while the muscle is paralyzed, the agonizing muscle on the other side, the muscle that helps the eye turn outward, is still pulling on it, and it'll basically stretch the paralyzed muscle, and the muscle will actually elongate over that period while it's paralyzed. So there is a permanent change that happens to the muscle while it's paralyzed. The effect does decrease, of course, when the Botox wears off at the 8-week or so mark, but there is a permanent effect.
Wow.
So
hey, we've covered a lot of topics on this show, but that might be the one that has blown my mind the most, man. I've never heard of anything like that. So that's a game changer. I mean, as a parent and having a kid come in like that, I'm thinking surgery versus Botox. I mean, how come we're not hearing more about this conversation? I know surgery pays, but Botox ain't cheap either. You know what I'm saying?
It's not. I think so. There are advantages to the Botox, but disadvantages as well. Just talk about the outcomes at the 2-year mark. 100% of the surgical patients where the esotropia was fixed, and in the Botox group, only 70%, which is still a reasonably high number. The authors advocate that the Botox group, it's better in small angle esotropias up to about 35 or 40 prism diopters, which still seems fairly robust to me. But why not just jump to Botox right away if it's not surgery?
And that's what I'm thinking. Take that as the first step, and if it doesn't, get to where it needs to, especially at 70%, then maybe as the child, well, I guess if they're younger, maybe they want to do it at an earlier age rather than waiting for them to get older.
So true. And here's the catch too, is that you can do the Botox. Some surgeons will do it on cooperative adults, it said, but they're still using general anesthesia to do this on all children and uncooperative adults. That's what the paper said. So, if you're putting the kid to sleep, the general anesthesia often is one of the least attractive parts of surgery to begin with. So it's not like this is an in-office procedure necessarily. That's probably part of the reason why it's not as attractive. But it is nonetheless a non-surgical, less invasive option for treating esotropias.
I love it, man. You've put a lot of tools in our tool belt on this show, man. From the Botox to, having a better conversation about ROP when patients walk in to, the raccoon side, right? I've seen images of folks that look like that, but I never even put, that name along with that, patient that walks in, but it makes sense, especially looking at that picture, right?
That's right. Well, man, I can't believe a week after this crash, this guy, he's going to be racing again this weekend, I guess. That's nuts.
They need to have.
I'm glad he's okay.
They need to have better protocols than that. I feel like when you have an accident, because I watched the video, man, and I saw how many times that car tumbled. I feel like when you're in an accident like that, you should probably be out a couple of months, right?
Man, I would think so.
Yeah, because I'm even thinking about whenever you have trauma to the eyes, right? We all know about angle closure. We know that it may not happen right away. It may be years down the road, right? It's going to take some time that may kick in. So, like, why would you put someone right back in the mix with, after having an accident and feel safe and comfortable with that? I certainly don't. So,
I wouldn't either.
I'm blown away on that one, man. But again, a lot of great information, a lot of great tools to put in our tool belt, great conversation pieces with our patients that come in. I think the main one that really lit me up was definitely the surgery versus Botox. But honestly, man, I really love the back to the Pheropter, the clinical case that you had. I mean, when it comes to patients coming in, listen to them, think outside of the box, find that solution that's going to elevate their life, and also be a walking ambassador for you when it comes to getting patients into your practice. So as always, my friend, I really appreciate you just putting together these amazing articles and sharing these amazing articles. Because every time that we do this, I actually take this and I go back to my practice and I implement it and I share it with my team members.
Well, I'm delighted to hear that. There's always lots to learn. Never stop being a lifelong learner, and always be willing to try things a little outside the box with your patients. You'll really get some great relationships and lifelong patients, like you said, formed that way.
Well, hey man, take us home, man. Leave us with some words of wisdom, my friend.
Well, it's as always, it's a pleasure to talk to you, Dr. Glover, and bring these articles to you. I'm going to get back to it, find some new ones for next month, and I hope everyone out there has a great September. Get ready for Halloween coming up.
I love it, my friend. Until next time, stay healthy, positive, and blessed. Peace.
All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the Defocus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars and make sure you follow us on all social media platforms. And until next time, be sure to keep it 2020, and we look forward to seeing you on the next episode.